right, folks. I think as the last couple of people trickle in, we'll just get started. So welcome. This is Health Homes and Supportive Housing in 2015, ... and beyond. So I'm Bonnie Mohan. I'm the director of the Bronx Health and Housing Consortium. And was anybody at the last panel that was in this room? Okay, many of you. All right, so some of you are going to hear the same thing. So a little bit about the consortium. We kind of were birthed at the same time as the health homes were, and we started by two organizations at Montefiore Medical Center and BronxWorks, a supportive housing provider, coming together and saying there's this health homes thing that's happening. We don't quite know what it is, but we should probably be working together. And since it's grown, we have over 50 organizations in our membership. We have a steering committee of representative supportive housing providers and all for health homes in the Bronx. And we've done a lot of work to bring people together and work out some of the issues, understanding that we're serving the same people. Your clients are their patients, and so we need to be working together. We need to be communicating. We've done a lot of work in that regard. Also acknowledging the housing issues present with people in health homes has really come out in the past few years. So we've done some research into the health homes in the Bronx and looking at the housing issues that are happening there. So that's a little bit about the consortium. And today, so now that we've kind of talked about that, I want to understand how many people here are familiar with health homes? Okay, yes. So, all right, so we'll try to keep like the Health Homes 101 level to a minimum, but to kind of give some context to what we're going to talk about today. So in the beginning of Health Homes, it was, it was pitched, this is this care management model. It's going to be a designated care coordinator who's going to coordinate all the services somebody requires, and they're going to be the point person to communicate with all the providers and get people connected to services. And as the program grew and we kind of got rolling with it, we realized that housing was a huge part of this. In the research that the consortium did, we found that more than 25% of health home members in the Bronx reported as homeless. So this is a huge concern, and then that kind of led to now there's this new acknowledgement, hospitals and managed care organizations kind of realizing what a big need there is for housing and needing to start working with supportive housing providers. And now there's been an investment in housing by the Department of Health in Medicaid, putting Medicaid dollars into housing, which is really a remarkable thing, and that's been through the Medicaid redesign team, supportive housing units. And then with that, then there became this new challenge of, all right, well, now we have a housing case manager and we have a health home care coordinator, and who does what, and how is that relationship going? And that's one thing that we're going to talk about a lot today. We have some folks from CUCS, a care navigator, Alfaro, who's going to talk about what they've done there at CUCS, and so we're going to kind of tease that out of how different organizations have worked through that issue. And now, we come to about 3.5 years in, and there are new issues that we're seeing. Housing is still an issue. Housing will always be an issue, but also now we're hearing that it's tough to get the medical side involved, and getting doctors to be involved, and getting appointments, and all these things that is the responsibility of the care coordinator. But how's that going? So we're going to kind of, and that's Kevin Muir from CAMBA Health Home is going to talk about kind of some bigger picture issues in the health home world, and what's next. Now there's DSRIP. How many people are familiar with DSRIP? Fewer hands. Okay, so we're going to touch a little bit on that, but that's kind of a beast of its own. So we're going to kind of tie all of this together. With that, I just want to first, housekeeping items: if people's cell phones are not turned off, please do that. And then we're also going to keep the questions for the end, unless there's some burning things that you want to ask as at the end of a presentation, we'll do a big Q&A at the end. So first, from CUCS, the Center for Urban Community Services, we have Carolyn Baginski. She is the program director of the Intensive Wellness Program. So Ms. Baginski obtained a BA from Queens College and an MS in Education in Rehabilitation Counseling from St. John's University. She has 15 years of clinical and management experience at CUCS, including 8 years as the Assistant Program Director of CUCS's Supported Employment Program before becoming the Program Director of the Intensive Wellness Health Home Program at CUCS. We also have Venus Alfaro, who's a care coordinator. Ms. Alfaro obtained her associates in human services from Metropolitan College of New York and has 7 years experience working in a therapeutic substance abuse program and 5 years as a case manager in CUCS's supportive housing site at the Times Square. And Ms. Alfaro has been working as a care coordinator in CUCS's health home for the past 3 years. So with that, I'll turn it over to Venus and Carolyn.
Can you hear me okay? No? Is this on? Hello? Can you hear me now? I think I'm leaning over so close. It doesn't go closer. I'm going to pull something out. Maybe I'll use yours. Yeah. Okay. Hello. Better? Yeah. Okay, great. So I'm pleased to be here today. My name is Carolyn Baginski. I'm the program director at the Intensive Wellness Program, which is the health home program for the Center for Urban Community Services. Just a little bit of a background of CUCS. We provide supportive housing units throughout the Bronx, Brooklyn, and Manhattan. We have about 12 different supportive housing sites, and we are about 2 years into being a health home for CUCS. We're a downstream provider. We get our referrals from our lead health homes, CBC and Mount Sinai. So we're getting referrals from the state that get funneled through the 2 lead health homes that we work with clients who reside out in the community in Manhattan and Brooklyn. At the same time, we're also serving clients in our own supportive housing units who are in need of health home services as well. So a couple of things that we're going to cover in today's presentation is that our agency for years has been providing case management services. So we're pretty good at providing case management services. Being care coordinators was something very new. Being a health home provider was something very new to the agency. So back in 2013, when the agency started really looking at, okay, how are we going to provide these services? We have case management services on site in our supported housing units. What is the care coordination going to look like? So with the way our agency typically operates is there was a work group was put together to really look at what are the differences between case management and care coordination. So that's going to be the bulk of our presentation, and I'm very pleased to be presenting today here with Venus Alfaro, who can speak to both sides. She was a case manager at CUCS for a number of years, converted over to being a care coordinator, so really is going to be able to speak about the work on the ground, give examples about both roles. It came up in the previous presentation. Somebody in the audience asked, are case managers still going to be relevant? Yes, and Venus is going to attest to how important the case manager role is along with the care coordinator role. Okay, and I'm in charge of the slides, so hopefully I remember to do this. Okay, so as Bonnie put out there already, hands went up about how many people are familiar with health homes, but I figured I'd put up at least one slide about that. So the goals of health homes are to improve health care, help clients stay out of the hospital, improve outcomes, reduce costs. So in our health home program, we have a team of 5 care coordinators right now. We have a team of 8 outreach staff, and we're growing quicker than we can hire. So we're in the process of hiring another 4 care coordinators, more outreach workers, because the list that we're getting from the state, on top of all the clients that are in need of health home services and our own supported housing sites, there's a lot of need out there of clients to serve. So I'm going to flip ahead. Sure, thanks. Okay. So why did CUCS need to really look at this paradigm shift of providing case management versus care coordination? As I said before, we have years in of providing case management services, and the agency felt pretty confident that we know what case management is, how to do it, but care coordination is definitely a different animal that we needed to look at. So 2 years back, the agency had meetings with our current health home staff and really identified what are the key roles of activities that case managers and care coordinators manage, and what are the differences. So what the agency did is listed out all of the different roles and identified what do the case managers do, what do the care coordinators do. So in the next slide, you can see that we came up with a list of 27 different functions and activities. They're really small, so I have handouts if anyone wants to grab this at the end of the presentation. So the next 2 pages just go over all the different areas. What we decided to do here was to just break out some of the themes and functions and to really talk about the differences. And Venus is going to give a lot of examples on the ground as to what these differences really look like in the work. So, with that. Okay. So the focus of work, nature of the relationship. As case managers, roles and all aspects of the client's life is really important in building a relationship with the client. The nature of the relationship is broad. It's extremely important how case managers and clients work together. Typically, case managers are working on a wide variety of areas, as most of us know, from benefits to substance use, employment, staying housed, managing their rent, living full and satisfying lives out in the community. Whereas care coordinators, the role is to build a rapport with the client, and the focus and nature of the work is more on the interventions and the coordination that happens across the team. So we may not be seeing and talking to the client every day, but as care coordinators, we are communicating every day, whether it's with the doctor, the treatment provider, the case manager, and coordinating all aspects of a client's health. Let's see. So, for example, I think Venus might have some examples of this. Right?
Yes.
So we're gonna.
How are you, everybody? Can everybody hear me?
Yeah.
Okay. Get it? Okay. So I did both roles. I did case management for 5 years at CUCS, and then I was offered to work as a care coordinator, and I think it was a very challenging job to be able to shift the roles. It was very challenging for me, and it took a lot of training and a lot of coaching from my supervisor to be able to provide care for the client. As a case manager, making the shift to a care coordinator was very different and challenging. One of the challenges I had was staying away from an individual-centered approach. By doing this paradigm shift, I realized that care coordination refers more to a team-based approach, meaning involving and coordinating care with health professionals. We try to bridge the gaps in the client's care, and we do this by navigating through the healthcare system. As a case manager, I realized I was doing whatever I needed to do with a client on all different aspects of their lives, like money management, medication monitoring, public assistance issues, or advocating for housing issues, like making sure that the lease was done on time, inspections, compliance, etc. When I switched to care coordination, I needed to really think about the approach in the work and focus on specific activities and tasks. I had to make sure that the focus was more of a team approach, coordinating the healthcare providers. I am currently working with a client who needed to be connected with a specialty provider to treat diabetes. When I did this referral, I obtained the documentation from the PCP and faxed the documentation to specialty provider. I also included the medical records. Like that, both providers will be in sync of what's going on with that individual's life. And I also, being that I'm working with a client that is from supportive housing, I also gave that information to the case manager. Like that, not only the PCP or the specialty provider are in sync with that, but also the case manager, being that the case manager is usually the one that does the escorting with the client. As a case manager, my focus was seeing the client, visually assessing and talking and taking the clients in the field all the time. I will also utilize the field time to bond more with the client. Ultimately, my goal was more for the client to gain my trust. As a care coordinator, my focus has been much more with providers and on the phone trying to have everyone in sync, like I said before. At the same time, meeting the client's needs. This allows me to have standard satisfaction of outcomes by achieving client's goal and filling in all the gaps. I have a client who called me panicking because her insurance didn't cover adult diapers. I then called the MCO, and I was told that they do cover 100%. I then communicated this to the client and directed the client what pharmacy to go to versus going to a chain pharmacy like Walgreens or Duane Reade's, and the problem was solved. As I was saying earlier, the shift of case manager relationship to care coordinator relationship is different, yet they're both very important. Remember, case manager is more of an emotional connection to the client versus care coordinator. We deal more with the people working around the client. However, we make sure that the client needs are being assessed and that someone that is working around the client is helping to meet those needs. Not just medical, but social as well. For example, are they getting the support on how to cope with the medical conditions, as well as meeting any other immediate needs?
Okay. In the area of proximity, intensity, nature of client contacts, case management services typically working closer with a client to their home, often in the same supportive housing site where the client resides. Case managers typically have more direct, regular client contact, which is typical for case management services. In the area of care coordination, intensity and nature oftentimes is strategic, and sometimes contact with clients is minimal, whereas more contact occurs with the client's care team. Contacts with clients is needs-driven, for example, to give important information or to coordinate services in the form of meeting a very focused and specific task. An example of some of the strategic and intense work that a care coordinator needs to do is Venus had a client who needed a referral for speech therapy after having a serious stroke. She spoke directly to the MCO about getting a referral, and she spoke directly to the MCO about getting a referral needed, and which was really helpful for the case manager. The contact was very purposeful, needs-driven, and showed reflected the progression of the work. Okay. Time management.
For time management, we also realize that it's really, really different. When a case gets assigned to us as a care coordinator, we first make contact with the client, and we spend more of 50% of our time with the client. The reason for that is because we need to make sure we find out who are the providers. Do you have any providers? Do you need any providers? And we also try to see if family members can be involved in the care. As a case manager, my approach was more towards the client, so it's really more being with the client. And if the client would allow me to go with him or her to the field, then I will make collateral contacts. Otherwise, I will get the information from the client, and I will go by that. As a care coordinator, as time goes by, my contact becomes more with the providers. Like I said, at the beginning it's more with the client, but then it changes, it shifts more to the provider, and I start having more provider contact, and I get all the providers in sync of what's going on with the individual. When I was a case manager, I would gather medical documentation. I would give it to the PCP and have the PCP educate the client. Again, my contact was based more towards the client as a case manager. As a care coordinator, it's critical that my work is guided by a medical provider. The knowledge towards the healthcare system is crucial to be able to have a success needed for the client. We sit with our nurse practitioner, go over assessments, care plans, diagnostics, or any other medical documentation collected to see what the next step will be. Also, one of the things that we also use our nurse practitioner for is for those times that when we have a hard time communicating with our provider, then sometimes we have found them more easily from coming from a medical perspective, helping us to make contact with the other medical doctor. I have a client who I will refer to as client A. She has been diagnosed with PTSD, alcohol dependence, cocaine dependence, cognitive disorder, HIV, asthma, history of domestic violence, and hypertension. Client A has been utilizing the emergency room every time that she feels sick or feels some sort of pain, refusing to see a doctor. She has reported to feel a fear of doctors or doctor's office. She feels that the more she tells her housing case manager about her personal life, she will lose her housing. Therefore, she becomes extremely guarded. Since moving into the building, she has had difficulty adjusting, and because of her substance abuse, her case manager assists on money and medication monitoring or any other housing needs, including entitlements. When I introduced myself to client A, I strictly spoke to her about her health and told her that I can assist her in connecting with providers in the community and one that she will feel comfortable with in order to live a healthier lifestyle. For some reason, she associated me with a nurse. So she opened up and started telling me that she doesn't understand why people are telling her she has HIV when she doesn't. I think that client A was open in speaking with me because the focus of my conversation with her when I introduced myself was crucial. I introduced myself in a health-specific way, as this is my role. I explained that my role with her is to coordinate her health care with setting her up with services specific to her health. I did set her up with outside providers, but she didn't feel comfortable, and ultimately ended up setting her up with the on-site provider of her housing unit, where she educates her about her HIV. Although she continued to be challenging for client A and continues to go to the emergency room, but has minimized drastically. I then received a call from a case manager from her MCO due to a recent emergency room visit. This has allowed me to facilitate the next step where I can include everyone involved in her care, including her social worker, her case manager, and her PCP. The coordination with the MCO was and it has been very critical in order for all the providers to come together. I needed to be the hub, especially because I already have developed a relationship with all the providers around her. Again, my role with this client has been at the beginning, like I said before, it was more with the client, but now that I have connected her with all the services, my role now is connecting more with the providers. Although we work with supportive housing, we also work with clients within the community. And one of the things that we have realized is that both roles are extremely important, case manager and care coordination. But the key to all this is communication. Thank you.
So we're doing pretty good on time, so are there any questions that anyone has for, yeah?
So for the clients you work with that are in the community, they don't have this nice case manager who's...
No.
How do you deal with that?
We try to connect them. If they have a mental health issue, then I connect them with a place that has case management and mental health.
I actually have a question. So for kind of along the same lines, I know that you, part of CUCS's model is to enroll people living in your supportive housing units into health homes, but people that come from the community or came through on an assignment list from the Department of Health, we've been hearing that a lot of them are kind of in it, they want to get the housing. It's that second word, that very misleading second word of health homes. So how do you feel like that's a challenge with kind of trying to demonstrate what you'll provide for them if they're maybe not concerned with their medical issues?
Well, yeah. I actually work with a client who his main goal was to get housing. We are actually doing the 2010Es for some of the clients that need housing. And in order to work with him, I made it very clear that I also need to be involved with his medical aspect or mental health aspect. In order to do the 2010E, I actually need to speak to a psychiatrist. So that was my gateway to getting into.
I have two questions. The first is, we've had a real variety of experiences with the care coordinators from different teams. So I was wondering, what are the mandated and then what are the recommended number of contacts that care coordinators should be having with the clients? And then also, just how receptive have you found medical and psychiatric providers to this kind of new role?
So both really good questions. The first part, about how many services can we provide per month? As per state rules, we provide one billable service per month, but that doesn't mean that we're only servicing the client once. It really depends on the client, the situation, who's involved, what's going on. There are many times where Venus is maybe talking with a client or a provider multiple times throughout the month. We're getting paid once, but we're providing more services because that's what the work calls for. There's other times where maybe it's just that one service a month, it's progressive, we completed the task, and then we can provide services the following month. But there are many times that it's throughout the month. The second question was?
How receptive have medical and psychiatric providers been to this new role?
It's complicated. And Venus probably can speak to some of that on the ground.
Well, working with hospitals, it actually has been much, much easier for me. The psychiatric department or the medical department are more open to speaking with us, and when they hear that we are care coordinators from a health home, they're very open to speaking with us. I'm really happy. When it comes to private clinics, that's the challenge. That's the challenge. And I've actually had a provider who hung up the phone on me. Yeah, so that's when we are trying to use our nurse practitioner to be able to guide us through.
Yes, two questions. What's the usual typical caseload of a case manager as opposed to a care coordinator? And the second question, I'm from Chicago. I'm here participating in one of the panels. And in Illinois, health homes are just beginning. So the care coordinators are hired by the MCOs. And Medicaid is going through MCOs, managed care organizations. So the Aetnas, Blue Cross Blue Shields. So do you have to deal with any, the second question is, do you have to deal with any care coordinators of the MCO community?
Yes, I actually, I get a lot of phone calls from the care coordinators from the MCOs, actually. And when a client goes to the emergency room or they have some sort of issue, they do call me and they try to see how can we work together with the client and try to meet that goal for the client. Like, for example, I have a client who recently was hospitalized for trying to commit suicide, and the MCO care coordinator called me, and we're working together. I told her that I had not completed the 2010E because the client hadn't given me all the documentation. So she actually got me the documentation that I needed, which was helpful.
Well, there's any fear that the MCOs eventually will say, we're not going to fund your care coordinators anymore, because we help them.
Yeah, I'd say that that's kind of, that's been a fear, I think, from the beginning, and I think what everyone's trying to do now is understanding that there's so many needs that this population has, and just trying to establish that it's not necessarily duplication, and I think it's what makes sense for each provider to be doing for the case manager. Between here, I don't know that MCOs are doing any care coordination. Does anybody know of anything differently? Yeah. So
small numbers are,
small.
but it's not a lot.
Yeah.
But
they have like case management programs that are existing, but in terms of this health
targeted
home,
populations.
yeah. So in terms of, it's not an overlap with the MCOs for us, and they've actually kind of been increasingly more wanting to work with housing providers and case managers and health home care coordinators to help focus on their highest utilizers too. And there was a caseload question too, case manager versus.
As a case manager, I had 33 clients on my caseload, and as a care coordinator, my caseload is 45.
Yeah. Sorry, I have a blind spot here, but yep, go ahead.
The question is, when you first started, you said that the case manager was more client-centered, and the care coordinator was less. Does the client's wishes play a role in their medical treatment, their medical care, as being client-centered?
Absolutely, we do actually do. We do a care plan for the client, but we also have to keep in mind what the provider wants. You understand?
So is what the provider wants more important
It's
than what the
both.
clients want?
No, it's actually, I would say that it's equal. And usually the client, when a client tells me, my goal is right now to better my asthma, it's probably something that the doctor has already told them, so they have that in their mind, and that's what the goal becomes.
This has caused a mix of credentialing versus salary versus funding changes in terms of the staff that you're hiring for care managers. Does the funding mix work, given the new credential?
Kevin, can you speak to me?
There aren't specific credentialing issues around care coordinators and the way that they're describing them. I'm going to talk a little more about some of the distinctions and how it's working, but I don't know if it does work or not, and I think I'm going to raise some questions about whether it works. And
any more specific to this kind of yes?
How do you manage the documentation? Do you use a shared electronic medical record where the care manager and case manager can see what's going on?
Yeah, but for CBC, we work with CBC and Mount Sinai, so that we have two different systems. And for CBC, I have a client who also is working with Pathway Homes, and I'm able to see their notes, and they're able to see my notes. So that's that. For Mount Sinai, in Mount Sinai, they're a little bit, I wouldn't say slow, but our notes are being more in Word. But the advantage that they have is that I'm able to see if the client went to the emergency room, I'm able to pull the records from the system.
I just want to ask you to hold your questions for now, we want to make sure that we get to Kevin's presentation, and then I know you'll have even more questions, but maybe he'll be able to answer some of them. So, okay. So Kevin Muir has over 20 years of experience implementing and managing nonprofit programs and projects. Thank you. I'm putting you to work. It's this, and it's really annoying. Okay, so I'm going to talk about how great Kevin is while he figures out the PowerPoint. Mr. Muir is currently overseeing CAMBA's participation in New York State's Medicaid reform, including the Health Home Program, the Delivery System Reform Incentive Payment, DSRIP, and the Health and Recovery Plans, HARP. Mr. Muir participates in a variety of committees and work groups, you're not kidding once you hear this list, including the Brooklyn Health Homes Governance Committee, Brooklyn Health Homes Clinical Committee, Maimonides Healthcare Innovation Awards Executive Committee, Community Care of Brooklyn's Executive Committee, New York State's Health Home and Managed Care Work Group, Billing and Quality Sub-Work Group, and the iHealth Board of Directors. How do you do all of that? Mr. Muir also has consulted on several learning initiatives, including Primary Care Development Corporation's Integrated Care Planning Initiative and Care Management in New York State Health Homes, prepared by Jocelyn Levy and Associates. Mr. Muir received his Master's in Public Administration degree with a focus on nonprofit management from the University of Arizona, Eller College of Management. Kevin. Ooh. Yeah, I know. Geez, I feel like I just did work.
Wasn't that talked about earlier? Thanks, everybody. I appreciate the opportunity to talk to you a little bit about where CAMBA is with our health home program. And I'm going to start out actually with a quick little story, since I love this morning's keynote. It was very touching, and I think we all had struggled a little bit afterwards to kind of get back into the rhythm of the conference after that. But I've had the opportunity, starting at the end of last year on New Year's Eve Day, I began fostering a 4-year-old child in my home, and it's been an incredible experience. And one of I'm going to link my story quickly to the healthcare field, because we're mandated to go to a specific foster care medical provider, and we're very lucky, actually. You think that you don't get to pick your pediatrician, and that would be a struggle to go through that, to not being able to choose that person. But we've been very lucky in that the pediatrician works very, very closely with the caseworkers in the agency and is very aware of the staff in the agency. So as I'm working with my baby, we're able to get great care because the doctor actually knows everyone and is engaged in everyone. I think that's one of the points that came up here earlier, and it's one of the points that I'm going to talk a little bit more about today as I go through my presentation about the importance of the connection with the provider. I just wanted to quickly introduce CAMBA, just in case there's anyone in the room who's not familiar with CAMBA. We started in the late 1970s as the Church Avenue Merchants Block Association, and primarily it's been a Brooklyn-based organization, but is now functioning in a number of different boroughs. We do a lot of different things. I'm going to quickly go through some of the scale of it so that you can kind of see. I work in the Health Services Division on the Health Home Program, but I also work on DSRIP and HARPs and home and community-based services and all those kinds of, any kind of Medicaid reform stuff I'm working on with the team there in the Health Services Division. And then we also have a full myriad of housing options for people, anywhere from shelters to permanent housing, transitional, all in the middle. We run a number of different economic development programs and legal services and family supports and education and youth development programs. We have about 150 programs spread out all across 60 different locations, so we're geographically pretty diverse as well. And we touch about 45,000 people a year, so we're fairly large in the number of people we're encountering. We have about 1,300 employees. And actually, is it Arturo? Yes. Arturo, kind of quickly to go to your question, I think one of the assets that we have as agencies that are in the community that managed care organizations don't have is access to the populations that they're really struggling to serve well. They oftentimes don't have the ability to access very specific populations and people that are the highest need individuals, and whereas we do. So as we struggle with that, and we negotiate contracts and do all the things that we're going to need to be doing in the new Medicaid realm, that's one of the assets that we have that we should definitely keep in mind. So that's a little bit about CAMBA. I'm going to talk not in a sort of academic perspective about our health home program, but just kind of give you some highlights about the program so you can get some perspective for the rest of the presentation. We talked a little bit about list-based enrollments earlier, which is when the state makes a referral to the plan, and then the plan refers to the health home, and then the health home refers to the care management agency. That's primarily how we've enrolled the largest number of people into our program. We haven't really relied as much, on our internal programs. So it's good that we have CUCS. You guys presented on how you were really working closely with your internal programs. We haven't done that as much. For a couple of different reasons. One of them has to do with the capacity to serve the number of people who need the services. So the list-based people oftentimes are not connected to care. When we encounter them, they are the least connected, whereas the people that are in our housing programs oftentimes have case managers already, and so they're already receiving some sort of service. So that's how we've justified it ourselves. We've actually grown 2,500 participants. We started out in 2011 with about 125 people in our COBRA targeted case management program, which is one of the programs that transitioned into health homes. So we're now at about 2,500, a little over 2,500 since 2011. So you can imagine that's a tremendous amount of growth. With that growth, though, we haven't even begun to touch the real need. We're constantly hiring because of the fact that there's so many people out there that need health home care coordination, and that's actually going to be further intensified by DSRIP, which is going to offer similar interventions around, care coordination type interventions in the different DSRIP projects that come up. So we're going to see a lot more growth in the future as well. We have about 100 staff that work in 4 different locations. We have, our frontline staff are called care coordinators, and the caseloads are somewhere around 50, usually 40 to 50 clients per care coordinator. With mixed acuity. We've sort of done the random distribution approach to assigning individuals. It may not be the best approach, but it's the approach we took. And what I mean by that is instead of trying to assign high acuity people to a set of care coordinators and then low acuity people to another set of care coordinators, we've assigned people randomly across the board. And we hope that for the most part that's been that they've been randomly distributed, although our caseloads tend to be on the higher side in terms of acuity. We've focused on developing very strong relationships with just 1 or 2 of the health homes in Brooklyn, as opposed to all 4. There are 4 in Brooklyn, and so we've really targeted and kind of spent a lot of our energy. A lot of the groups that you just listed on that list were Brooklyn Health Home committees that I participate on. And I spend a lot of time at the hospital, at Maimonides Medical Center, which is the original provider that got designated. So that's important. I'm going to talk about care coordination in housing, just to kind of set the stage for the rest of the topics I'm going to cover today, and help kind of make this a little more relevant for everyone. One of the questions that we still have 3.5 years into this is sort of what is the real vision, the longer term vision. Arturo raised it, the direct point about, is the vision that the plans will provide care coordination? Will our supportive housing case managers continue to provide case management services? I was in another presentation this morning, and Commissioner Sullivan of OMH said that their intention at this point was that they're going to continue to have services in supportive housing settings, and that they're not intending to have health home care coordinators or other care coordinators replace case managers. So that seems to be their intention for now, but I think it's always been a question for all of us, and it's one of the reasons why we've struggled with this. What are the roles? Is are we going to have both? And that's an important question. Or are we going to replace? I already talked about that. And then the other question is, can both exist at the same time? And I think CUCS has done a really good job of presenting a model that would allow for both to exist at the same time. I would be one that would argue that they need to. And the reason for that is because as we talk more about care coordination is exactly that. It's coordinating the care among a number of providers. And if you look at where case management exists right now, it exists in the medical setting, it exists in the housing setting, it exists in the substance abuse setting. There's case managers in almost all of those settings where our clients and our residents go. So if we suddenly decide that health home care coordinators are going to replace all of those case managers and that we're just going to have one title for it, the fear that I have is that the health home care coordinator won't be supported well enough. They won't have the funding to do all of the different tasks that those people do. I just don't think it's possible. I think that we need to count on the fact that there is a housing care coordinator, case manager there to help with just things like, for example, the lock is broken on your door and you need to get into your apartment. That's not something that a health home care coordinator really should be focused on. They should be more focused on health-related topics. But if we were to replace them, that's what would end up happening, as we all know. The other big question I think that we've been struggling with is around how housing fits into Medicaid redesign and DSRIP. And this morning's presentation also talked about the fact that of all the, I think there are 29 or something, I'm not sure the exact number, but I think it's around 29 different performing provider systems applied to become part of, formal performing provider systems as part of DSRIP. And only one of them asked for supportive housing as one of their 10 projects that they were gonna do. However, it seems as though housing does play a role in the goals. I mean, as we all know, housing is one of the most important issues. So the question is how does it fit? I was at another presentation recently where someone from Health First was there speaking, and they were talking about how they were struggling with this question about how Health First is going to cover and pay for housing services. It's a real big question because how is it sustainable? I don't think that the plans and the PPSs and the accountable care organizations that exist today have really thought about this from a long-term perspective. Once you provide housing for someone, obviously they're going to expect that housing month after month, year after year. They're going to need that ongoing service. People don't often, as we know, graduate from housing as hard as we might try. So it becomes a real question about sustainability and how we're gonna integrate housing. And so these are just questions that we still have. I mean, 3.5 years into health homes and ongoing DSRIP, we still have a lot of questions. I already talked about the different types of case management that exist. I already made that point, so I'm going to go on. Care coordination versus case management. I'm going to present a little bit of a different perspective. It's not that much different, but it may just be a little bit of a kind of different words to present on this. But care coordination is looking at how the system can meet the needs of the individual. So how does the system, and I think that actually is similar to what you all were sharing, the focus on the provider. How do you get the system to sort of meet the needs of that individual? And the case manager is more focused on helping the individual to navigate through this, especially in New York where it's really, really complicated, this crazy complicated system that we have. How do we help them to get through that? So that's how I would kind of define the roles for how we look at it at CAMBA. Some of the promises of care coordination I think are important to highlight, and I'm going to talk about whether we've achieved these things. I don't think we have entirely, so we'll talk more about it, but shared care plans is one of the things that we've talked about. Integrated services where people can go to one place and get multiple types of services. Breaking down silos of care between the medical, mental health, and different social determinants, including housing and substance abuse issues. These are some of the things that we've promised. How to achieve these things, you got to have, in order to get the outcomes that we want, you got to have some kind of coordination going on, real coordination, and that happens through co-location, coordinated assignments. And what I mean by coordinated assignments is when you have a provider that's assigned with a care coordinator, and all of that provider's patient panel is basically assigned to that one care coordinator, so that the relationship between the care coordinator and the provider is tightened and strengthened by that coordinated assignment. And then HIT is sort of been this, this promise that I think we all know we're in that for the long haul. It's not going to happen overnight, but we think that HIT potentially can bring us a lot of resources and efficiencies in the processes. Venus mentioned alerts earlier. We are starting to get alerts from hospitals through the RIO and then into the care management platforms that the health homes manage. So when one of our clients is hospitalized, we get an alert. Hallelujah! Like how many of us have sat there and wanted to know? We find out, in May that our client was hospitalized in January, and it's like, well, what can we do to help them with that when that's how we find out? So that's sort of an obvious one. It's really helpful. It's not happening across the board, but it's happening much more often enough that we're pretty busy responding to them. So that's a really good sign. But in order to have coordinated care, one of these things has to really be in place. And then it requires accountability and coordination among all the team members. And the reason why I kind of added this point in there is because Venus talked a little bit about some of the struggles that she has with interacting with providers. Today, an individual provider, even within the hospital system, is not accountable to us. They don't have to respond to any of our case managers, to any of our care coordinators. They're not accountable. And the reason why they're not accountable is because there's no financial mechanism to hold them accountable. They don't get paid to interact with us. On the other hand, we get paid to interact with them. So we're going to talk more about that too. So using technology, I talked about alerts, sharing care plans and protected health information, what technology provides the link. So this question about technology and which one provides the link is a big question, because I've seen a lot of agencies out there spend a lot of money investing in their own internal system. Brooklyn Health Home, which is one of the health homes that we work with, and many of them have their own system, have invested in online systems that our care coordinators just log into, and that's the system. I don't need a system. I don't need to invest $100,000 or $150,000 in a system. What I would benefit from, is to have access to RIO information and be able to connect the RIO to my internal client management system, which I do have to have some sort of a system internally, but I'm not able to do that oftentimes because it's not funded, and I don't believe that. My belief is that we shouldn't have to be paying for that. That the funding for HIT is flowing all around us. It's like you can't go 10 feet without getting hit in the head with a $60,000 grant for HIT. But we're not getting it. Excuse me. We're not getting that. That wasn't an intentional. That wasn't anger coming out there. So these are things these are real questions. You have to really think about, strategically whether or not an investment in some sort of HIT is necessary from your agency perspective, and then if it is important, how can you get that funded? Interoperability. This is a topic that you may or may not have heard about, but it is one of the most critical topics that exists out there when it comes to using HIT as the solution, the care coordination solution, so that all of the providers that Venus talked about can be in communication with each other if they're not co-located. Interoperability is critical, and we don't really talk about it enough, and it concerns me, and so I kind of threw it in there. But so the question is we're struggling with the same question that we did when we talked about DVDs and Blu-rays and for those of you who may be a little bit older, and I won't call you out or anything, but beta versus VHS, right? So there's a struggle between these two different technologies, and society is trying to decide which is the right one. We're doing that right now when it comes to the question of interoperability and data. Oftentimes it's around medical data and psychiatric data, substance abuse data, but it's not around social determinant data, housing data, and things like that we encounter. But eventually, we're going to get to a point where we've agreed on the right language that we're going to share and we're going to use, and we're going to be able to do plug and play where you just plug in your system into the other system, and you're going to be able to communicate. And that's going to make things a heck of a lot easier. And it's critical. The reason why it's critical is because you all are individual providers, but if you kind of put yourself parallel to an individual medical doctor who's in the community, in many ways you're like that individual medical doctor. That doctor, she may have an EHR in her practice, but it's not easy for her to plug that EHR into the system. It's not any easier for her than it is for you. So in many ways, we had the same struggles as the individual primary care doctors when it comes to interacting with the health homes and with DSRIP and these different systems. And then obviously, what data points do we need to share? I would argue that we need to include social more than we do. I talked about funding. We need to go where the hard to serve people are, shelters, hospitals and clinics, the criminal justice system, obviously, where people are in public assistance and public interventions, other public interventions. These are the places where we can go and sit and physically be co-located in order to be able to have an impact on the outcomes that those individuals have. We're doing that some. CAMBA runs a number of shelters. We have care coordinators that are in those shelters. We're also partnering with a number of hospitals and clinics where we have care coordinators on site, and that's really the way it gets done. You do have to have buy-in from your partners though at those sites. It's not enough to simply have a seat in the clinic. You have to also have significant buy-in from the medical team, so that they're willing to come and talk with you and make referrals and share information. So that stuff is really, really important. I put down in terms of successes, relationships are important. One of the reasons why I do invest as much time as I do in going to different committees and stuff like that is because your interactions with other providers are critical in order to help your patients or your clients be successful. The way that happens is through individual people. One person talking to another person, developing a connection, smiling at each other, shaking each other's hands. That's critical. That actually makes a difference. We don't talk about it a lot, but it is really important in terms of the client's outcomes and the ability to serve them. So gaps in the health home program. DSRIP originally was going to be was going to unfold parallel to the health home program. So as the health home program was coming out, they were also making proposals around getting a reinvestment of some of the savings, and it just so happened that DSRIP was delayed until this year. But had it happened, it would have been very helpful to us because what we've noticed and what I've been arguing throughout my talk so far is that providers aren't all on board, and DSRIP sort of is the opportunity. It's the optimistic side of me saying that the DSRIP dollars potentially have the ability to provide that financial incentive to cause doctors to interact with us. Like they might actually get paid to do a case conference. Okay, and that would really make a difference, right? So hopefully that will happen. And we're looking for things like that to happen, and those things are being talked about. So these are all good. Let me just see here. Sorry, I know I'm.
It's 2 minutes.
Yeah.
I have a bell.
Yeah, you might need to use the bell. The provider versus care coordinator based care coordination. One of the things that we're realizing 3.5 years into this is that we have about 25. I said we have about 2,500 people. The problem is that the way they've been assigned, it's been very random. And I mentioned provider coordinated assignments earlier. We really need to be assigning care coordinators to providers, rather than assigning them to a list of 50 people who are just sort of randomly spewing across the city. So, because what happens is that we end up with 25 different clients, and then they have, how many providers do they have? 1,000? 1,500? And we're going to have the relationships that I was talking about earlier. We're going to be able to develop those relationships with those providers. It's going to be very difficult. So I think the future of health homes or care coordination, whether it's health homes or PPSs or however it gets structured, is going to focus more on pairing care coordinators and doing with providers and doing that coordinated assignment that I talked about earlier. I think that's going to be more and more important. I think we're still working on achieving the original objectives of health homes. Care coordination has not come to fruition across the board. There have been isolated places where care coordination is happening, but until we get the providers on board, it's not going to happen. We need to continue to work on streamlining workflows for frontline staff so that they can use the data systems, the care management platforms and things to actually do better work. They're not doing that for us yet. We need to balance clinical objectives and cost administrative. So what I'm talking about here is we all want the best clinical outcome, but does that really look like 50 people per care coordinator? I mean, honestly, it's a lot. It's a lot of people. We all know, some of you had, back in the day, we had how many, 12, 15 in some programs. So now we're talking about 50 people per person. So is that clinically the best? And if it's not, then how do you develop a business model that allows for the best clinical option? So what I'm finding right now is in our current struggle with health homes is that we're kind of having this battle between the business model and the clinical model and what works best. And I don't know how to resolve that because the dollars don't always support what people, the kind of the best optimal clinical intervention that would be provided. And so we're gonna have to figure that one out. But it's a struggle right now. And then my last point is supporting care management agencies with transition to risk-based models. So we're not. I mean, I'm assuming that many of you are either supportive housing providers or in the nonprofit sector, in the CBO sector, and we're not really set up. We're not designed to handle risk very well. We don't have huge chunks of money that's set aside to kind of manage this kind of transition to value-based purchasing, which is what's going on right now. So the question is as the hospitals are being supported with their transition through DSRIP. With $6.242 billion, right? What will support the community-based organizations with the transition that we need to go through to be able to provide true, strong community-based services that will potentially be able to replace emergency room visits and inpatient stays that were happening before? So how do we invest in that in a coordinated way? To date, we've spent no money on planning through DSRIP. DSRIP has spent probably $12 million just on planning with the PPSs that have applied. They've spent no money on planning for the community-based organization group. But we need to plan. We need to be strategic and think about all the things that we need to do to be able to provide the services that we're going to need to provide in order to be successful with DSRIP. And so that's one of the struggles that we're at with now. So I'm happy to answer any questions, and thank you for going through my long, boring discussion. I appreciate your time. Yeah.
I just wanted to.
Yeah, ring the bell.
Great. Yes.
I'm wondering, so as health homes, are you responsible for collecting data or reporting any data that shows that there have been Medicaid savings as a result of the coordinated care?
Well, that's a really good point. I mean, our staff enter data into the care management platform that the health home provides us with. We're not a health home. We're a care management provider. So the health home is responsible for collecting that data that you described. It's very expensive to collect data. So in my view, we shouldn't have to carry that expense. If data needs to be collected, it should be collected at the health home level, and it should be presented at the health home level, and they should have the right fields in the database to be able to capture that data. So we have traditionally resisted any effort to try to collect spreadsheets from our staff. We're not very responsive to that request. If somebody sends us an Excel spreadsheet and says fill it in, because we believe that if you have a care management platform, you should use it, and you should design it to accomplish the goals that you just described. I think those goals are real. The risk in taking the attitude and the approach that I've taken with that is that you might end up with, in 3 years from now, without the data that you need to be able to sell yourself to the managed care organizations. And so you have to be very careful about how much you kind of resist that. But it's a good question.
And I think that's where a lot of the managed care organizations come in and provide, in looking at that, they're the ones that have that information of the utilizations. So now that everyone's, enrolled in a plan, that they're the ones that are really going to be tracking that. And we're seeing some increased, relationships between the plans and supportive housing providers to kind of say, and health homes to say, hey, these are our top 100 highest cost utilizers, and, they're in your health home, 10 of them are in your health home, let's make sure that we are prioritizing these. So there are some efforts emerging to kind of keep track of that and to make sure that we're focusing efforts on the people that are going to show cost savings. Yes.
As far as the health home structure, it was my understanding that it was linked to a certain time frame, like 2016 or something like that. Is the goal that the health home will transition into the DSRIP, or will it remain independent because it's funded, it's really a mandate from the federal Affordable Care Act versus a statewide?
I mean, this is the Arturo question he asked at the beginning, which is it's a similar question. I think the answer is that health homes as a model will eventually become part of a bigger system, most likely. The intervention itself will probably look similar, and so all the work we're doing right now isn't just going to go away.
Okay, you're just building.
It just might look. It might look different. It might not be called the same exact thing. It might be, but it might be part of a bigger set of services that are being offered. But I wouldn't. This is my opinion. I wouldn't anticipate that it would go away, but it could very well become part of a PPS, and just another service that gets offered. That probably won't happen, until year 5 of year 3, 4, and 5 is where you're going to start seeing some of that occur. But you're right about the plans in the first 2 years of us billing the plans directly, which doesn't start until January of 2016. That the first 2 years they're mandated to pay the state designated rates. So that would go into 2018 really, the end of 2017, and then after that, after 2017, the beginning of 2018, there's going to be some question about how health homes is funded. But the service itself, what we're building is care coordination. And that's what's critical. That's what's needed, and that's what's critical. It's just a question of, is it successful, and can we design it the right way?
I think when you're building a health home network, though, at least in our area, some care providers have been hesitant because they see it as a temporary thing and not a systems continuation. Or at least that's what we see locally.
I don't think it's temporary. I think care coordination has been demonstrated across the country as an intervention that can work if it's done right. And so I think that what we're working on in the health home model and the way it was funded is to try to create a care coordination infrastructure that didn't exist. It was very small before. It was COBRA. I think they mentioned this morning there was 1,000, OMH, targeted case management, positions. It was very small before, probably less than 60,000 people. But here we're talking about hundreds of thousands of people. So
I think this is a really important topic because I really am very concerned about DSRIP. I think it's a buyer beware situation for the not-for-profits. I see this potentially as an opportunity for hospitals to get hold of a lot of money, and really very unclear how any of those funds will flow down to the not-for-profits. So for health homes to change would be, to me, challenging. And I think we all need to really watch it. I think we need to be on top of it. And I think we absolutely need to make sure that the DSRIP dollars are not eaten up by hospitals and that the not-for-profits do the work and don't get paid. I think this is an extraordinarily big danger for the not-for-profit field. And Kevin knows that I feel that way.
I agree. I mean, I think there's a lot of risks in DSRIP. The interesting thing about DSRIP is that the risk is also sort of, it goes all the way to the top. So if New York State doesn't reduce the avoidable hospitalizations by 25%, then the entire state loses money. So we're all sort of in it together, and that's complicated, and we're not used to that. We're used to we're in it for ourselves, and we're going to take care of our own contracts, and we're going to do a good job, and we're going to get another contract. That's not the way DSRIP is going to play out. If you've got there's been a couple of PPSs that I've been watching very closely because I'm really concerned about their viability, and the reason why I'm worried about their viability is because if they fail, I'm not going to get paid, So, and it doesn't seem like that wouldn't be the case, but it is. So, very complicated.
Yes.
And folks go down for value options, and as it gets that far downstream, if CUCS is paid basically one time for serving a client for an entire month, all of the promise of rewarding such entities for cost savings is lost in the current shape. Can you speak to that?
Say it again one more time.
The question. The kind of the promise of the HMOs and the cost savings. Part of it was that the providers would be rewarded for doing a better job, for reducing the amount of unnecessary care received. As CUCS just described it, they're paid one time for serving the client over the course of a month. They provide far more services, but that's not at all consistent with a model that would reward cost savings or measured consumption, et cetera, et cetera.
Yeah, I mean, absolutely. That's still a fee-for-service model, and we're still in the. That's fine. We can be in the fee-for-service model now, but we're not going to be in 5 years from now, theoretically, right? If 90% of the Medicaid dollars is not fee-for-service, so I hear you. I mean, I don't know what the answer is. One of the things that I can say is that we have not gotten any cost savings incentive dollars from the health home program, and that was an original promise from that. So that's part of when I brought up this issue about DSRIP is designed to manage a 25% reduction in avoidable hospitalizations. So many of our hospitals in New York State are vulnerable, and if you reduce their avoidable hospitalizations by 25%, they're going to go out of business, right? They're going to shut down, period, the whole thing, it's gone, right? So DSRIP is designed to prevent that from happening. What DSRIP doesn't do, and in some respects health homes did the same thing, is it doesn't pay attention to us. It doesn't pay attention to how do we get to a point where at the end we're able to function in this new value-based model and do it successfully. And it's not going to be easy for us to get there because, again, we don't have the reserves that many for-profit entities do. So it's a real question. I think it's one that we need to be voicing as a community. I don't think the dollar amounts are small that we need to be asking for in order to allow for that transition to happen. I think they need to be very large. I'm not asking for $2.5 million. I'm asking for $500 million. That's really where I think we need to be. $1 billion, because that's what's happening right now in the state. There's a lot of investment happening, but it's not happening in our area. With health homes, the opposite was true. Health homes did not pay attention to the provider community. So there was not. Health homes was all about downstream care management agencies in getting engaged, but they completely left off the medical provider. So that again, I already shared about that. So.
Yes.
One of my experiences with the shift to care coordinators, where many of the agencies and the preventive agencies were ICM workers. Now we are going to have care coordinators. And I'm finding that there's a limitation of what their role is from when they were ICM workers to care coordinators, where we in supporting housing locations need that extra at-risk management care. And we seem not to be understanding or giving the care that we needed. So I wanted to know what was the difference between ICM, or what is the difference between ICM and care coordination? Because at one time, if you called an ICM worker, if someone was needing to see their ICM worker, they would come. Now I'm only allowed 30 days, and that's if it deems any criteria that meets the 30-day limit. So So that's,
Part of it has to do with the business model. Again, I was saying, like, you can't do it with 50 people, and right now, a lot of agencies, not all agencies have done it like CAMBA, but a lot of them have, where it's sort of a random distribution of clients. So your high-need clients are thrown in with your low-need clients as well, and they have a big caseload. So the same intensive kind of response that you used to get, you're not going to necessarily get today. That's not the way we intend to have. Like, we're not done, we're not finished, we're just sort of like in the middle of this transition, and I think we're in an awkward spot with it when it comes to this problem that you're presenting. But I think we want to get back to where we can have 12 to 15, 20 person caseloads for those really high need people, and then maybe 100 or 150 person caseloads for the really low need people who just don't need anything that month. But it's just a question of how do we get there from a management perspective, and we're not there yet. But I think that's the goal. We have to get back to that, because that's where the care happened, and if we don't, we're gonna end up spending just as much money on those individuals as we did before. So.
It sounds like there's sort of countervailing motivations that, given the high caseloads that are required, and that currently fee-for-service model, that the most efficient means of doing that is with something that you already do have a case manager, that you can sort of siphon off those needs to the case manager, while just focusing on the little bit of the care management, the care coordination. On the other hand, because this program is meant to be an effective demonstration of reducing hospitalizations and ER visits, that those who are already connected to care are already kind of reducing hospitalizations, and so kind of the motivation for a higher demonstration is with those people who aren't connected at all. And I think that it sounds like you, like with CAMBA, you really prioritized those who aren't connected. Can you talk about how that sort of affects the business model, that you are dealing with somebody because they aren't connected at all beforehand, then you get the issue of all of these other needs that aren't being addressed and that you're hearing about because you are their only connection.
Yeah, I mean, part of the struggle has been that the need is somewhere up here. And like, whenever people talk about competition in the health home and kind of DSRIP world, I always say this is not a competitive environment. And the reason why I say that is because the need is up here, and the ability to provide that need is down here. We're somewhere down here. And so if we were, and I'm including all of us, if we were up here or even up here, then we might be competing with each other. But we're down here. So part of what our decision was is that we were sort of looking at the individual needs, and we knew that we couldn't ever meet this bit, so we wanted to help the state and the city, the Brooklyn, to get to a point where we were serving more people. And I think we've only scratched the surface, and there are some 80,000 people in New York City in the HARP eligible people that are being pushed into HARPs in the next 6 months. That's going to happen. Some of them are in care already, but a lot of them aren't. And who's going to provide care coordination for those people? I don't know. I mean, we don't even have the workforce that's trained to be able to do that. I mean, and nobody's planning that. Nobody's got a new. I mean, I shouldn't say nobody. There are programs out there that are working but they really needed to happen 5 years ago so that people could be graduating now, and then entering our employment with us. So we're struggling with this capacity issue. Then I think that it's all about like what decision you want to make about how you. You're right though. If you could have I said it earlier. If you could have a housing case manager, you need it. You need that. It's not optional to say, oh, we don't need housing case managers anymore now that we have health homes. It's not going to work that way.
That's, there was a panel this morning that had that was kind of health home, supportive housing, and managed care organizations. And we had somebody here from Health Plus America Group that said, we have case management programs, and we were talking before about some of the plans do, and that can be, it's about finding ways to supplement the services, because no know, as we're figuring out distinctions between care coordination and case management, when there's not a housing case manager involved, a care coordinator is not going to be able to like kind of assume that role. So it's about getting them connected to the programs that will, and maybe, you know, the managed care organization is that resource. Maybe it's, you know, through a substance treatment program or, you know, an employment program, whatever it is finding, there, you know, there's stuff out there and getting them connected. Yes.
I want to make two comments, if I may. One is that it's kind of like there's all kinds of hospitals, well, there's all kinds of health homes. Some of them are quite closely coordinated with providers, and some of them aren't. So it's not like this one thing. So I think it's really important to learn who the health homes are, who your folks are living, you know, the folks who are living in your buildings, which health homes are they involved with, and some of them, they'll be quite different, so you'll have to develop very different relationships. The other comment I want to make is about the CBOs. I think that you're actually in a stronger position than you think, because the DSRIPs and all of that are going to need you. You know, a hospital cannot discharge somebody, shouldn't, into the street. They need to discharge people well, and they need the services. But they're going to need all these DSRIP types to think that they're going to, you know, hold all the money or wrong, because they're going to need your services in order to have people live in communities well. Otherwise, they won't be able to meet those targets. You're not going to be able to reduce hospitalizations and emergency room visits by not focusing on community-based organizations, because they're you're the places where people are living and the kinds of services they need. So the smart ones will work with you. And I think it's a good idea to get involved with the smart ones and start developing those relationships now.
So has there been any outcome data as far as the health home program being effective for reducing emergency room visits or hospitalization? Is there any indication to say that this is actually an effective program that's preventing or slowing down the use of emergency rooms and hospitalizations?
It's minimal. There's minimal data available, and it doesn't necessarily reflect what we would all think that it would be. You know, that it would be this dramatic impact. But part of the reason why is because of the things that I talked about. Like where you don't really have care coordination occurring, and to her point that she just made. It's very diverse. So in some instances there is real care coordination happening. Even within our program, we have instances where that's happening very well. But for the most part, across, like if you take the bulk of people that are in health homes, they're not getting true care coordination because the doctors aren't on board. And until they are, we're not going to get those outcomes. The outcomes have always been. The evidence shows that the outcomes come from true partnership that happens through co-location and possibly through partnership that occurs through HIT, through health information technology. But it has to be real and substantive. And until it is, you know, which we don't have in New York State today, you're going to have trouble getting those outcomes.
Yes.
Prior to supportive housing, I did work at inpatient sites, and often the challenge was getting the patient to agree to the referral to SCM, SCM, ACM. With the increased focus on medical coordination, is that leading to a higher rate of buy-in from clients, or is there the same level of resistance to being referred to?
You know, Venus, what do you find with clients, their willingness to get kind of referred to other programs, and is there resistance to being referred out?
I was accepting a care coordinator.
Yeah.
Right. Well, I would say it's like a 50-50 chat, you know. I did, when I first started as care coordinator, I actually did outreach. So I was outreaching my own clients to build my caseload. And the supportive housing clients actually saw me, they agreed a little bit more because that wasn't in their building. So they felt like they weren't going to lose their housing, and I'm able to trust this other person. You know, so I actually got a better outcome with those people.
For the clients that were outreaching in the community, who are the lists are coming from the state, I mean, we really have had to develop and educate our outreach workers so that when they're going out talking about the program and the service and what we can provide, the more educated and informative our outreach teams are when communicating with clients out in the community, the more successful we have been. It's when we have outreach workers who don't understand the process, or, when a client, says that they have a certain illness, that the outreach worker struggles with, eliciting more information. But the more education that we can provide to our outreach staff around how to talk about what a care management agency is and what we can offer, the more successful enrollments we see that we can have.
I was just to quickly say, engagement rates are very low in health homes. They're under 20%, and that's being generous. They're really under 15, 12, 11. They're really low statewide. And what we've experienced is we've experienced higher rates because we have a designated outreach program. But when we encounter someone, they tend, especially those people that have never had services before, they want some kind of help. They want some kind of connection. That's what we've experienced for the most part. Not everyone, but a lot of them are, the reaction is, yeah, you can. That's why this question about, are there too many people contacting you? Like, there's 5 case managers from different places. I think the opposite is the case for most people out there, that they're not getting any supports. And
so the list gets generated in the initial contact without the individual, who's like, it's not like they had to sign the SWOA after the CAS, so you're outreaching to them without them having to reach
cold.
them.
Yeah.
Cold calls, yeah. Knocking on doors.
Knocking on doors. Sometimes we've actually outreach clients in the streets that have been on the list.
Somebody mentioned earlier something about credentialing for care coordination, and I wondered if any of you could speak to that. I'm an administrator in providing supportive housing now, but when I was a clinician and health homes were just starting, we had COBRA, and then it started the health homes and everything. It was like, when I would work with the care coordinator, it was like hit or miss. Either they were amazing or they were terrible. And I'm wondering, are there credentialing processes? Are there things like, that they're going to help to develop like a standard of care or anything like that?
Not really.
The Brooklyn Health Home has a very extensive training for care coordinators and outreach specialists. They have a separate training for outreach specialists that they've done through 1199, and it's extensive. It's like 12 weeks. There's actually two cohorts that they have to go through, 12 weeks and 4 hours each week. So it's a big investment in time, and they're covering a lot of the basics that you're sort of seeing when you get that one that you kind of, you're like, oh, what is this? So yeah.
Well, it just felt like really useless. Like you're getting this money every month, but there's no services whatsoever.
Right.
And again, I know that's not true of everyone, and I certainly run into some that were excellent, but it seemed like there was no consistency in terms of the standard.
The gentleman who brought up credentialing was from Value Options, and as this moves under managed care, credentialing will become more of an issue. It isn't today, and how credentialing gets worked into health homes, we're not sure yet exactly what that will look like, but it will happen, and it will become more formal. And trainings, 1199's developed a really great training, so trainings will become more readily available.
I also think that when you said that sometimes the care coordinator doesn't do anything, I think also it has a lot to do with how many times they get paid on a monthly basis for the service. I think that has a lot to do with it too,
I'm sure, and a huge caseload. I mean, I'm sure that all comes into it. It just, I know, and it's a new thing that everybody's trying to figure out.
Yeah, and that's been kind of the model, was to set people off on their own, and every health home, as I said, every health home's different and is set it up differently. There's some standardized things, but really it's an experiment, it's all a big experiment, and so it's going to look very different from one to the next, and unfortunately that means that there's going to be some organizations that are not up to par, and a lot of health homes have referral numbers and hotlines where you can call and should report that back. I think that they want feedback, but yeah, it's just, well, yes.
along those lines of some being great and some being terrible, can we assist clients who are already connected to one terrible health home in transferring to a different one? Yes.
Yeah, but I actually had a client that wanted to change the health home to come to work with us because I was working with someone that she knew. And it all depends on the client. The client has to be able to contact the MCO and the health home and say, I want to switch. It all depends on the client.
But yeah, that's definitely there's a process involved, but yeah, it's still like client choice at the very first, yeah. I thought I saw a hand for a second.
No,
Change your
that
mind.
was my question. As a service coordinator, you find that the former ICM, now is a care coordinator, health home agency, to do it now is ultimately unethical. Because the idea is to reduce hospitalization. And one would think that by having a care coordinator, that they would be able to assist you with getting care outside of needing programming that for a person who's at risk, that would help to eliminate hospitalizations. But in my case, with someone that's not been the case because that shift from ICM to care coordinators, and I'm assuming that they're having difficulties and shift in paradigm and it's been ineffectual. So I was wondering, as a service coordinator, could I call to ask for a referral for a switch? But you say that the client has to be the one to ask for it.
Yeah, I mean, you can talk to your client about it if that's what they want, but ultimately, yeah, it has to be their decision to change. So it is 3:16. So feel free, if you have other questions, you can come up and ask us and the panelists. Thank you so much. Thank you.